think it's 5 o'clock. Let's go ahead and get started.
So welcome everyone. My name is Nick and I coordinate this group with Dr. Chopra, who's the chair. So the ACP is sponsoring this long COVID interest group with the goal of bringing together healthcare providers who care for patients with long COVID and to help provide education, resources, and to help them share clinical experiences with experts. So we have members joining from both Washington State and other parts of the country. Just as a reminder, our sessions will take place on Zoom on the last Wednesday of every month at 5 p.m. And lastly, it always helps us to help get comments going in the chat. So feel free to put questions or what you're hoping to get from the session today. And I'll be monitoring it and can flag questions as we go. Other than that, at the end, we'll have a quick poll of a couple questions that we hope you can please answer. And with that, I'll turn it over to Dr. Chopra and Dr. Hayes.
Thank you very much, Nick. Hello, everyone. Welcome to this session of the ACP Long COVID Interest Group. As Nick said, we are focused on providing you with resources and strategies from our experience with post-COVID patients in the clinic. I'm honored to have with us today Dr. Janna Friedley, who is Professor of Rehab Medicine at UW Medical Center and the Chair of the Department of Rehab Medicine. She is the Associate Director of the Administrative Core for the UW Clear Center for Musculoskeletal Disorders and is also the Executive Director of the Post-COVID Rehab and Recovery Clinic. Welcome, Janna. Thank you so much for joining us today.
Hi, thanks for having me. I'm happy to be here, and I'm so happy to see so many people joining today to hear about this. It's great.
Thank you. Thank you very much. And my co-host today, who is here to co-facilitate this session, is Dr. Douglas Hayes. He is an internal medicine hospitalist and core faculty for Skagit Regional Health. He is adjunct clinical faculty for Pacific Northwest University of Health Sciences College of Osteopathic Medicine. And I'm so happy to have him join me here today. And of course, we have Nick Franco. Nick is a research coordinator in the Department of Family Medicine at UW and is the coordinator for this group as well. So thank you so much, team. And with that, we'll go ahead and get started. And I will hand it over to Doug for the first question.
Wonderful. Well, thank you all for having me. Super excited to be here and super excited to see the audience we have this time. So sort of to get us started, one of the sort of ways to get us started, Dr. Friedley is a rehabilitation functional and mobility specialist. When we talk about post-COVID, and we have a lot of folks who are experiencing sort of post-COVID related exertional malaise, which limits the amount of exercise that they can do, it leads us to a lot of questions about, what other limitations besides just the exertional malaise do we end up seeing, and what are our patients experiencing with this long COVID?
Yeah, well, thanks. So again, thanks for having me here. And just as a little bit of background, additional background, I started the post-COVID clinic at UW in the very beginning of the pandemic. So in April, May of 2020. So we've now, and in our clinic, we've had up to 17 different physicians at any given time. So it's a very high volume clinic. So we've seen, now thousands of patients over the last 4 years in the clinic. So a lot of what I'm drawing on is our own experience in the clinic, and our team also does a fair amount of research, and I have a particular interest in pacing as an intervention for post-exertional malaise. So I'm just about I'm one of the PIs for the Recover Energized trial, which is a pacing trial. So we're about to get launched in that clinical trial. So I can talk a little bit more about that, but what we see in our clinic just in general in terms of limitations that people have, fatigue, brain fog, cognitive impairments, and pain are some of the most common symptoms that we're seeing in the clinic, and exercise intolerance. And as I'm sure all of you who have worked with patients that have long COVID, these symptoms can be very debilitating, to the point that people are unable to work and unable to do the usual activities that they want to do. But fatigue and brain fog, I think, are probably the most limiting of the symptoms that people experience. And so we'll talk a lot about post-exertional malaise, but I do think it's really important when you're talking with patients with long COVID who have fatigue to ask them what their activities are, what they were able to do before they had COVID, what kinds of activities that they're able to do now, and what their response is to when they try to exercise. How does that affect them, and what do they feel a day or 2 days later after participating in exercise, to really get an idea of how limited they are by exercise intolerance and post-exertional malaise. Hopefully that answered your question in a roundabout kind of way.
Thank you, Janna. And there's a recent study that was published which shows that muscle abnormalities worsen after post-exertional malaise in post-COVID patients. What are some of the skeletal muscle changes that have been observed? And if you can talk about the mitochondrial damage context as well, and how does it impact exercise tolerance?
Yeah. So there's been a fair amount of research in chronic fatigue syndrome, prior to COVID, and chronic fatigue syndrome and people with post-exertional malaise, looking at exercise intolerance and the effects of exercise on muscles and metabolism. And so we've known a fair amount about this prior to COVID, and there have been studies that have looked at cardiopulmonary exercise testing and how people with chronic fatigue respond to cardiopulmonary exercise testing. And now, for the first time, there's been some really interesting research that's just come out that's looked at this in people with long COVID. So the study that you're referring to is a study that was published in Nature Communications in just this year, in January 2024. And we can probably put I can put the reference in the chat for people who are interested. That's the article that you're talking about. And this was a case control study where they had healthy controls and then people with long COVID, and they did cardiopulmonary exercise testing on 2 separate days. So they did it twice and repeated the cardiopulmonary exercise testing. And what they showed was that people who have post-exertional malaise, and particularly on that second day when they do the repeat cardiopulmonary exercise testing, when they look at, they did muscle biopsies, and they also did, all of the serum testing as well. They showed that people, produce lactic acid much faster. So they went into anaerobic metabolism much quicker with shorter intensity and duration of exercise. And in the muscles, they showed quite a bit of inflammation and myopathy. And so this was one of the I think more exciting research studies that showed some very clear physiologic changes in people with long COVID in response to exercise, and I think gives more credence to what patients have been telling us all along, that when they exercise, they feel worse. And so as physicians try to push patients to exercise more and more in sort of a graded exercise training protocol, patients actually with this condition feel much worse. And this was really the first time I think that in long COVID we were able to show some of the physiologic changes.
Yeah, wonderful. So I think that study is the same one that mentions exercise-induced myopathy.
Mm-hmm.
Is there a proposed role of viral persistence and immune dysregulation going on with this?
Yeah, I mean, I think there's been a lot of research that has looked at whether viral persistence is part of what's going on. I think the jury's still out in my mind about that question. I'll talk about a related study that's sort of unrelated to the impact on muscles, but does suggest that there may be some viral persistence in the gut. So I don't have a good answer to that, but I do think that may play a role, at least in some patients. But clearly there's, all of the research that has been done has pointed to changes in the immune system function of these patients and altered immune system function underpinning a lot of the changes that we're seeing.
Janna, post-exertional malaise or PEM is, as you said, one of the most debilitating for patients. How do we screen these patients for post-exertional malaise? And if you can talk about PEM DSQ and how can providers use that in their practice?
Yeah, so I think the most important thing is that you need to ask about it because if you don't ask, patients oftentimes won't tell you, and sometimes patients, it takes a while for people to recognize that what they're experiencing is actually post-exertional malaise. They'll understand that they have ups and downs and good days and bad days, but until they actually are tracking their activities and their symptoms, they may not put two and two together that they have a particularly stressful day or have more physical exertion, and then the next day and 2 days later they are experiencing worsening of their symptoms. I think the big take home is that you have to actually ask patients and really get patients to try to make those connections between what their activity levels are and how they feel the next day or 2 days later. I think with post-exertional malaise, it's important to recognize that it's not just physical activity that can lead to post-exertional malaise. It's also cognitive or mental stress that can cause it. So you sort of have to think about all of the demands on a person's energy and how that impacts the next day or 2 days later and beyond, and ask about those things, and that can be a little bit hard for people to piece together unless they're actually tracking their activities and symptoms. And post-exertional malaise can involve a sort of a wide range of symptoms. For some patients, it's muscle aches and pains. Other people, it's sort of feeling heavy or feeling really fatigued or just they'll describe being drained or things like that. But so that the symptoms of post-exertional malaise can vary person to person. So I think understanding how a person defines it for themselves and what symptoms those are important. So you can just ask patients about these things, and it's really out of proportion response to exercise or cognitive mental demand. And they feel, oftentimes people will say, I feel like I ran a marathon, even though they just walked up the stairs. And the next day they feel that kind of like they've been run over by a truck kind of sensation. There are not a lot of standardized forms or questionnaires that people use to assess post-exertional malaise, but there is one called the DSQ PEM, the DePaul Symptom Questionnaire PM, and there's kind of a longer version and a shorter version and some modified versions, but essentially this is a pretty quick standardized questionnaire that asks people about the frequency of the post-exertional malaise symptoms, the severity, and how long they last. So how many, is it a one day, 2 days, 3 days, or more of symptoms after they have these after they do exertion. So it is one way to be a little bit more systematic about screening for post-exertional malaise.
That's really, really helpful. Thank you. Can you help me sort of understand, or help us understand, kind of walk us through the workup of exercise capacity, specifically through that rehabilitation lens? What type of evaluation would you be doing for these patients? And then for the primary care providers in the group, sort of when should they be starting to think about referring to a specialist?
Mm-hmm. Yeah, so I always obviously start with the history, and I think you can get a lot of information about someone's exercise capacity or exercise tolerance from the history. So asking people, what were you able to do before COVID? What are you able to do now in terms of exercise specifically, but also just general activities. And then I always, as a rehab doctor, I always try to gauge what people's goals are and what activities are important to them, and how far away they are from reaching those goals. So, obviously everybody has a different goal. For some people, it's getting back to running. For other people, it's just being able to go to work every day or walk, take their dogs for a walk or something like that. So for me, it's trying to gauge what the patient, what's most important to the patients. And then, as I just mentioned, I always assess for post-exertional malaise. And then also in the history, I ask questions about orthostatic intolerance. And many of our patients have degrees of orthostatic intolerance and autonomic dysregulation that are kind of underpinning some of what's going on. So I ask people about change in position and how that can influence their symptoms, whether they notice palpitations or heart rate changes when they go from lying down to standing up. Oftentimes our patients now have Apple Watches and Fitbits and are actually tracking their data. So asking them to share that with me can give me a really good idea of how their body is responding to activity over time. There's been a lot of research on heart rate variability and using that to help and showing that people with chronic fatigue and post-exertional malaise and POTS, specifically orthostatic tachycardia, have lower heart rate variability, and so a lot of the apps and the devices can track that. So patients will often tell you about that. So a lot of it comes from the history, and initially. There are some sort of objective measures that you can use in the clinic. I would say most of the time, if patients have these kinds of symptoms and they're coming into the clinic, that they're walking from their, you can gauge what their exercise capacity is if they tell you that they can't walk from the car into the clinic and have to use a wheelchair or, a device. I usually don't put people through like a 6-minute walk test or something like that in the clinic, because that oftentimes can be so fatiguing that they tell me that they've been that just that in and of itself will put them into a relapse or a post-exertional malaise for the next few days. So I'm very careful about asking my patients actually to demonstrate things in the clinic, and only do that if it really is going to inform what my treatment goals are. In the clinic, one thing that I always screen for, if patients tell me that they have orthostatic intolerance or they have heart rate variations and palpitations, is screening for POTS using the Nassau lean test. So that's something that I use in the clinic a lot. And although it's not directly exercise capacity, it gives me a lot of information about how to guide people in terms of their exercise. So I can talk a little, if it's helpful, I can sort of hold off and talk a little bit more about the Nassau Lean test and POTS sort of separately, or I can do that now. But I want to get to how I approach sort of talking patients through exercise and getting them started with exercise.
Yeah, I think this was actually very helpful. You talked about the patient encounter a little bit and what you tend to emphasize. And the next question that I have is talks a little bit more about actual advice that you give to patients. And you have talked about pacing and the 4 pillars of pacing before. In light of this new study talking genital damage, does your advice change about pacing, and how early should physical therapy come into the picture? And what should our advice be for patients in terms of recovery?
Mm-hmm. Yeah, so the way I approach exercise and advice, for me, I don't think that this study changes the way that I approach things, but I do think that it has changed for clinical practice in general. So what I mean by that is, for and just as way of context, I think, Anita, you know this, I myself had COVID early in the pandemic and had 9+ months of pretty significant autonomic dysregulation type of symptoms and post-exertional malaise, and could not get back to regular activity at all. So for me, that experience for myself really guided how I approach counseling patients about exercise and getting people back in to exercise. So I always start with restorative exercise and have patients avoid the higher intensity exercise that can lead to more inflammation and trigger some of that post-exertional malaise. So avoiding, running and heavy weight lifting and things like that are pro-inflammatory. And have people focus initially first on breathing exercises and gentle stretching, range of motion, and low intensity aerobic exercise like walking. And oftentimes have people do yoga and that kind of restorative exercise first and focus on that. The caveat to that is and one of the reasons I ask about orthostatic intolerance is that, if somebody has POTS-like symptoms or orthostatic intolerance, oftentimes even the yoga exercises where you're doing a lot of inversions can be triggering for people. And so I try to focus initially on recumbent exercise and really be mindful of people's position and how that affects their symptoms. So I usually will have people start I provide them with just some guidance like that and some basic information about exercise to get them started. But if they aren't able to engage in exercise or have difficulty understanding how to incorporate exercise safely without triggering their symptoms, then I will oftentimes have them see a physical therapist. And a physical therapist can be very helpful with helping patients to track their heart rate and using their heart rate as a guide, using step counts, and helping patients to figure out how to incorporate exercise safely without worsening their symptoms. So that's typically how I approach starting to work with physical therapy. It's since physical therapy costs money, even with copays and depending on insurance. and that it can be hard for patients to go to physical therapy. I usually start with just trying to get them to do a home exercise program before engaging with physical therapy.
I think one very good point that you made, which is so important for primary care doctors, is restorative exercise. And the other thing is, a lot of our patients will come in and say, oh, I'm trying to push myself to do the things that I used to do. I really want to get back there, so I try and push myself. But that push and crash cycle that they get themselves into is not ideal. And pushing themselves can lead them to pay for it for the next few days. So I think that's very important for us primary care docs to also remember and to, tell our patients. So off to Doug for the next question.
Yeah, I was just going to reflect as well that it's also important as a hospital doc that I make sure my post-COVID patients admitted, I don't push them to the point of crashing into unable to discharge. So
yeah. Well, and truth, my experience has been with patients that oftentimes it's the patients that do, especially not necessarily on the hospitalized side, but on the outpatient, mild to moderate COVID. It's when they push too soon during their recovery to try to get back to that high level activity and exercise. Those are the ones that seem to, in my experience, to experience worse long COVID. So I think it does speak to the need to take time to recover from COVID, and adequate time, and have people very gradually get back into exercise after their acute COVID infection.
absolutely. So there's been sort of the landmark recent study that came out that I think has been really just eye-opening to a lot of us who deal with long COVID, sort of explaining the pathophysiology, and it's sort of raising the kind of question about impactful ways we may be able to help treat patients, specifically with long COVID. And that's the recent study that came out in Cell that's showing lower serotonin levels secondary to decreased tryptophan uptake. Can you talk about that one a little bit?
Yeah, absolutely. So this was, as you mentioned, a study that was published in October of this last year in Cell. It was a study or a series of studies that was done at the University of Pennsylvania. And they looked at patients with acute COVID, patients who had recovered from acute COVID with no long COVID, and then patients with long COVID. And they showed that people with acute COVID and people with long COVID symptoms have evidence of viral persistence in the gut. So going back to that question of viral persistence and inflammation in the gut, and that causes a decreased absorption of dietary tryptophan. So the tryptophan is in turkey and chicken and spinach and tofu, and I think there's a list of foods that are rich in tryptophan. But tryptophan is a precursor to serotonin. It's also a precursor to niacin and to melatonin. And they, in this study, were able to show that patients with acute COVID and patients with long COVID also have decreased serum levels of serotonin. So this was the first study, I think, that really showed that connection between gut health and overall health. I strongly believe that the gut is really critical in all of this. But it also was the first study that had a direct link to serotonin levels in long COVID symptoms. And we early on, from the very beginning in the clinic, started treating people with SSRIs for long COVID. So this and seeing that patients were getting better. And so this, I think, really helped to have us understand why this might be, and also has been really helpful for me to help explain to patients why treating somebody with an SSRI is not saying that this is a psychological condition, or that we're ignoring the long COVID symptoms and just focusing on mental health. symptoms that commonly coexist, but is actually treating the long COVID symptoms. So I think this has been a really, for me, a very interesting study and probably one of the most helpful ones. I'll say, people always ask, is there clinical trial data looking at SSRIs? There are some ongoing trials. There hasn't been anything published yet, but there were two studies that I think are interesting that were helpful. One was early on in 2020, where they did a randomized controlled trial of fluvoxamine in acute COVID. So they treated people for 10 to 14 days with fluvoxamine acutely, and showed that there was reduced morbidity and mortality from COVID with that. So this might help to explain why that was successful. We started treating people with fluvoxamine in the clinic, but generally speaking, it's not very well tolerated. There's just too many side effects with it. And then there was another study that showed that patients in a psychiatric facility who were taking antidepressants actually had lower risk of developing COVID infection and severity of COVID infection than those people who were not taking antidepressants. So there's some another evidence that antidepressants might be helpful in preventing severity of acute COVID. But there's no data on which one is better than another. So I usually just choose the one with the lowest side effect profile, or one that, if they have other comorbid conditions, helps with anxiety or depression or pain or other things.
This is super helpful, and this study does bring to the forefront the importance of the gut-brain axis and the disturbance of this connection in past patients. So my question was about prescribing SSRIs to patients even if they do not have anxiety or depression in post-COVID in past patients. But I also wanted to get your advice on probiotics. I know that you have talked about supplements, and you do talk about a host of other supplements as well. But in clinical practice, my question is two-pronged. A, would probiotics be beneficial? And B, should providers consider SSRIs in patients who have either post-exertional malaise or chronic pain? And I think you answered part of it already, but yes, that's my question.
Yeah, so obviously I do prescribe SSRIs, and I have been prescribing SSRIs for people without depression and anxiety. The reality is depression and anxiety is so common in these patients as well, that oftentimes it is helpful, for multiple reasons. And we also have done some research in our clinical practice that has shown that the majority of the patients that come to see us have some sort of pain as well. So musculoskeletal pain, the wide variety of different pain conditions. So oftentimes treating with Cymbalta or something that can do a dual purpose for that also is indicated. So I always, of course, gauge patients' willingness. I frame it very carefully so that patients don't feel like I'm discounting their condition and blaming it on a mental health condition. So I think you have to explain it well, and this study helps that. But I do use it a lot. As I said earlier, I think the gut is the key here. So I always encourage people to be on an anti-inflammatory diet, which is a heart healthy diet anyway, and try to reduce sugars and alcohol and other things that are pro-inflammatory. And I do, the evidence about supplements, and supplements is a whole nother topic we can talk about. But in general, there's not great evidence for any particular supplements, with a few exceptions. I think that there's a growing body of evidence about the benefits of probiotics and anti-inflammatory properties of probiotics and benefits generally. So I think it's a low risk thing to encourage people to incorporate probiotics either through food or supplements. The question is always which one is better, and I don't think there's good evidence one way or the other for any particular kind of probiotic at this point. I actually think, Anita, I think I've mentioned this to you before, but I actually think that somebody should do a trial of fecal transplants for long COVID. I think that to me would be a very interesting study, because I think the gut microbiome is really impacted, and there's such a link between the GI symptoms and other things going on. But that's I would love to see that study.
So there's a question related to this. Do you recommend ordering serotonin levels for long COVID patients?
I don't, serotonin levels fluctuate quite a bit. And so I don't order serotonin levels because I wouldn't really know how to interpret that. If the serotonin level is normal, I think they could probably still benefit from an SSRI. So this brings up the question about lab tests. And I think one of the things that we struggle with is that there are so many different lab tests out there, and there's a lot of long COVID panels, and people are spending a ton of money on these really extensive lab tests. And Julie, who wrote the comment, I think knows from a research perspective, there's a lot of value to doing all sorts of tests, and looking for biomarkers, and so a lot of the studies are doing a real deep dive to help to understand better what's going on. But on a clinical level, I don't think that there's yet any good evidence for many of the lab tests that people are using. And so I think patients are spending a lot of money on lab tests and coming back with these results that don't really help to guide treatment at this point. So I'm very cautious and a little conservative about lab tests. And I want to make sure every single lab test that I get, I can interpret it, and I can give that it can lead to some sort of treatment.
Yeah, thank you for that. That's I think we all in internal medicine and in medicine in general always look for the evidence-based lab that will help slam the nail in the coffin. So kind of changing a little bit on the topic, a lot of our long COVID patients end up filing for disability coverage. And as we learned last month, 44% of post-COVID patients cannot return to work, and about 51% of those with post-COVID end up having to work fewer hours, which I find staggering. And that leads us to the process of basically the physicians filing for disability paperwork, which I think for any of us who've had to touch disability paperwork, it's daunting. And it's not just the process, but the paperwork is crazy. So what are some of the resources that are available to help with this process? Specifically, is there any role for having help from like vocational rehab or any other help with filing disability process?
Yeah, so it can be daunting. And I'll just add from our clinic data, the vast majority of patients, so I think it was 81% of patients, if I'm remembering correctly, Anita, you can correct me if I'm wrong, but from our clinic, at the time of their first visit, reported that they were unable to work. So this impact on people's ability to work is huge. So I can tell you how I approach this issue in our clinic and some general guidelines and things that I think you should be aware of in primary care. One is that the ADA does recognize long COVID as a disability, so that came about in 2021. So technically, there are some legal protections for people with long COVID. I have found that patients do benefit from work accommodations, and that there are a number of things that we can do to help keep people at work and advocate for changes that will allow them to go back to work. Some of I use a lot of the data that they tell me about their post-exertional malaise symptoms and what activities that they can tolerate to be able to guide what kind of work accommodations that I recommend. But it's often teleworking, reducing driving and the time from driving. Closer parking so they don't have to walk longer distances, particularly like people who work at Boeing or big places where there's a lot of walking that has to go on. Changing their schedule so that they have flexible schedules and can take breaks when they need to, and those sorts of things can be really helpful. Even things like reducing some of the noise and some of the light stimulation that can cause some of that sort of overload can be helpful. Having sit-stand desks and there's a wide variety of accommodations that I think can be helpful for patients that I advocate for. We're fortunate in our clinic to have vocational counseling, which is incredibly helpful for patients, and they serve as an advocate, help patients to come up with those work accommodations and help people navigate sort of thinking about disability and thinking about changing careers and other things if they need to. But I know that that's not available, in all systems. But if you have access to a vocational counselor, that definitely can be really helpful. I also will, oftentimes, if it gets to a point where there's a really contentious disability process, we don't have a diagnostic test for long COVID, but I do think that the cardiopulmonary exercise testing can be helpful for people that have pretty severe, fatigue and post-exertional malaise. And neuropsychological testing can be helpful for patients with significant cognitive impairment. So I sometimes will use those to help give me some, and physical therapy assessments to give some more quote unquote objective data that can inform some of the disability process. I do disability paperwork all the time, so I totally get that it's overwhelming. I just want to reassure people because I've been doing this for 20 years, doing disability paperwork. It's not that you're stupid, that you can't figure it out. It's that the forms make no sense they make absolutely no sense. I don't know who came up with any of these disability forms, but honestly, they just don't reflect what actually happens with patients. And so if you're feeling like you're struggling figuring out how to fill them out, it's not you, it's the forms. And they're not really geared towards people that have these relapsing, remitting symptoms and good days, bad days. And so I usually will just ignore most of the things that are on there and just write in free text and make sure in my notes that I back up what people are experiencing. And we in the clinic have some kind of standard language and things that we use and references, and we can package that to provide for people that can help to support those efforts. I think May, do you have your hand up?
Yeah, I think people have questions now, so we are going to open up the floor for questions.
Yeah, hi, Dr. Friedley. Thanks so much for such an amazing talk. One second, I think I'm echoing.
Oh, you're good. I don't hear an echo. Maybe
Go ahead. You can, Emily, you can ask your question if you like.
Can you hear me better? Can you hear me better now?
Yeah, that's fine. You're good.
Okay. Yeah, Dr. Friedley, thanks so much for such an amazing talk. I've learned so many new things, and this is really interesting. So I was just wondering whether there's any data that shows that long-term treatment with Paxlovid showed any benefit?
Mm-hmm. Yeah, so there's a number of clinical trials that are going on now, looking at different treatments for long COVID. So the Recover Network is Recover study is one national NIH-funded study that's doing 5 different platform trials And so I mentioned one of the trials is a pacing trial that I'm leading with Cindy Bateman. And they are doing a clinical trial of Paxlovid. And so the jury's still out about whether Paxlovid is helpful for long COVID. So many patients will ask for it. Many patients will come to me having been prescribed Paxlovid from other long COVID clinics. We currently are not prescribing Paxlovid until we get those clinical trial results back to guide us in terms of how long you should treat people, and if there's you know, a certain subsets of patients that are that it would be better for. So we haven't been doing that, but so I don't know, but it's a great question. And I'm hoping that there will be an answer soon. Emily?
Yeah, thank you. This has been just amazing. I was curious, Dr. Hayes sort of used the phrasing of we have the mechanism now, and I was curious, do we feel like the serotonin thing is really kind of the mechanism, or do we feel like there are lots of mechanisms that are in play for different people? Just wondered if you wanted to comment on that.
Yeah, it's a great question. I think I think there's multiple different mechanisms. There's a lot of different research. I think that have looked at different things like microclot, the role of microclotting in some patients, and you know, the effects on the mitochondria and other things that can't be solely explained by serotonin. So I certainly don't think that it's the one thing that's underpinning long COVID. And I think as we get a little bit more refined in our diagnostic ability, we'll be able to sort of subgroup patients better. There's been a lot of work that's shown that there are kind of subgroupings of different clusters of symptoms, and probably that means that there's different causes. I think it's also important to recognize that long COVID doesn't exist in a vacuum. And so there's so many other comorbidities and things that people bring to the table that influence you know, the course of long COVID and the impact of long COVID. So it's really important to understand what their underlying medical conditions were, and what the social determinants of health and all these other you know, things that can potentially influence it. I tend to think of COVID like lighter fluid. It sets everything on fire. And so any premorbid conditions people had, it makes them worse. And anything that people are predisposed to, it makes them worse. But I think in general, we have a pretty good handle on that this is an immune system response. It's just that the immune system is pretty complicated. So it affects people in different ways, I think. Hopefully that answered your question, sort of.
Yes, absolutely.
And then there was a question earlier in the chat that was asking about if there are other scales or questionnaires that are helpful in assessing long COVID symptoms and associated functional impairment.
Yeah, that's a really good question. There are some long COVID symptom questionnaires that people have developed, but there is not a lot of research on validated symptom questionnaires. The Recover network uses a symptom questionnaire. I think that they developed as part of their work. And then we are using a variety of different outcome measures, and you know, looking at like the Promise 29, you know, promise measures that integrate with Epic, that are more generic tools. I'll have to look at providing more specific answer about the long COVID symptom checklist and questionnaires, and maybe I can do a little bit of digging to get the one that I'm thinking of that the Recover network uses, because I don't have that link currently.
Hi, I had a quick question. I don't know if you may have already addressed this before. I was a little late in joining the meeting, but are anybody doing like N of 1 trials? Because this long COVID seems to be a kind of a basket with a lot of different things in it. and what works for one patient may not work for that. I mean, maybe 30% of the patients, even if you have a great mechanism and a mechanism-based treatment, may work. So sometimes this is more like a personalized therapy in some of these cases, I would assume, rather than more like a single agent, single treatment kind of a thing. So, and I mean, is there any framework that we are using, or have you used yourself like N-of-1 trials for some of these patients?
Yeah, I mean, not officially from a research perspective, but I think that's basically how we approach things in clinic. Is everything, and I tell patients everything is trial and error. And when I'm prescribing, there's so many different options out there for supplements, for medications, and they're all for the most part now geared towards symptom management. So I always try to start with one thing at a time and measure the effect, and then move on to something else. So in my clinical practice, I'm kind of doing N-of-1 trials in that way, because for patients are oftentimes starting 5 or 10 different things at once, and then they have no idea what's helpful and what's not helpful. But I haven't seen anything published, in terms of standardizing an approach for that. But I think that's a really great point.
In your experience, is there a particular treatment or set of treatments that seems to be helping more than other, or supplements, for example?
Yeah, well, so I'll say in our clinic, the one medication that I have found to be the most helpful for my patients, for more of my patients than not, is low dose naltrexone. And so I've been using that a lot in my patients. That has been particularly for people who have myalgias, joint pain, fatigue, and brain fog. That kind of triad of symptoms, it seems to be most helpful for. And so that of all the things that I have tried over the last 4 years, that has been the single most effective medication that I've had, and is relatively low risk. And it can be low cost depending on how you administer it. If you have them go to a compounding pharmacy, there are some compounding pharmacies, because the dose is not the standard dose. If you go to a compounding pharmacy, the price range is from $25 a month to $130 a month. But there are some mail order pharmacies that will do it on that less expensive range, $25 a month range. And then I oftentimes have patients compound it themselves at home, using the 50 milligram tablet. And that actually works pretty well because patients can titrate the dose themselves. So happy to talk a little bit more about that if it's of interest. But otherwise, SSRIs, low dose naltrexone. We have used some of the stimulant medications for fatigue. That's been very hit or miss, and they come with a lot of side effects and interactions. And then on the supplement side, again, I think there's a lot of theoretical reasons why many different supplements might be helpful. I think the sort of key ones that I tend to steer, I always encourage people to get as much as they can from their diet, and so making sure that they have a healthy diet. But at minimum, maybe a multivitamin, vitamin D, especially here in Seattle, for many patients. Omega-3 fatty acids. There's some evidence. There's some, I think, evidence for coenzyme Q10 and NAD and chronic fatigue syndrome, and that's one of those mitochondrial support supplements. So there is some evidence, but I'm very careful to make sure that I let patients know that there's no good clinical trials yet of any of the supplements. I have not found any particular supplement to be, one patient will say it's super effective, another patient, will say that it's not effective at all. So I have not found anything to be uniformly effective for patients. So it's a lot of trial and error, which comes with a lot of cost.
Thank you.
Everyone, I quickly just wanted to mention as we finish up with the last question or two here, there is a poll that we would all really appreciate if you are able to fill out. If you have a second to fill it out, please do.
And I think in the meantime, we have another question. Rancher, you can unmute and ask your question.
Thank you so much, Dr. Friedley, for the great information. So my question is, does treatment with Paxlovid for acute COVID prevents long COVID?
Yeah, I think the research is pretty clear that Paxlovid can help to reduce the incidence of long COVID. I think anything that, in general, the more severe COVID that you have initially, the more likely you are to develop long COVID. And so I think all of the strategies to reduce the initial impact of COVID. So vaccines, Paxlovid. There was a study of metformin as well that showed that there may be some reduction of risk of long COVID. So I think in general, I would encourage. I'm fairly liberal in encouraging people to use Paxlovid. And many of the patients that I see, these are repeat infections because they've already had COVID and long COVID, and I think there's no evidence that it's not effective in patients that have long COVID. That sometimes comes up.
Thank you so much.
Well, I think in honor of time at 5:56, thank you so much, Janna, for coming and participating in our long COVID session this time. Every month that we have done this, I have just learned so much from the group, and it's just been so informational. So thank you for your insight and expertise. Quickly, just want to also thank Washington State ACP for continuing to host us and sponsor us in doing these events. We will be working on getting the recording of tonight's session up and made available to anybody who wants it. So once we can get it posted, that will get emailed out. We do have the Washington State ACP Long COVID Interest Group, which we're continuing to work on bringing you high quality education and updates. So I know Nick posted the link in the chat to sign up on the form if you're not on our mailing list yet. And we will be having our next session in about 4 weeks, where we're going to focus on the cardiovascular complications of long COVID. So just once again, thank you everyone for all of your time this evening. And we hope you have a wonderful night.
Great. Thank you so much for having me. It's great to see everybody here.
Thank you very much, Janna. I really appreciate you giving us time, and there were so many valuable insights that you shared. Thank you so very much.
Have a good evening.